All right, in the interest of time, let's go ahead and get started. So good afternoon to everybody. Welcome to Module 4, Gathering Community of the Coming to the Table, a Pediatric Primary Care Healthy Weight Initiative for Children and Families. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NEC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, let's review a few housekeeping announcements. First things first, by joining this online event, you automatically consent to this event being recorded. This event will be available for playback at a later date. Again, you joining this event automatically consent you to this recording. You have either chosen a phone line to call in or using computer audio. Both options completely fine. I always recommend, though, that if you're in an area where Wi-Fi can be sometimes a little bit spotty, it's sometimes best to use the call-in feature. That way you do not miss any of the live content. Of course, throughout this entire Zoom module session, you have the ability to share your screen, and I'm sorry, not share your screen, share your video so we can see your faces. You do have the ability to mute and unmute your line. We do ask that if you're not contributing verbally, please keep your line muted. This is really to avoid any sort of background noise interference. Throughout this module, maybe in the 5th module, and possibly some future modules which we'll talk about later on today, there'll be some ability to get into what we call as gallery style, where we'd like to see your faces and have an interactive conversation with you guys. Chat box, of course, located either at the top of your screen, which you take your cursor and toggle that down, or located in the lower right-hand side of your computer screen. Simply type your comments, questions, or concerns into this box at any time. We'll either answer you back throughout the chat or live during today's session. Friendly reminder, so today's event is being recorded. Please keep your audio line muted. This is really just to avoid any sort of background noise interference. And the chat box is open. We're ready for your comments or questions or concerns. Going to turn things over to Jenny. As usual, the floor is yours.
Thanks, Liz. You do such a great job with that.
Thanks.
Welcome, everybody. We're glad for those of you who are continuing on this journey with us. We're continuing to prepare that big meal at the table, and this week we're talking about inviting in the community. Last week we talked about the medical exam room, so it was pretty centered on what happens in the primary care setting. And today we're going to talk about things that community health centers are very familiar with, the community, and how to collaborate well. Next slide. So if you haven't been with us before, we try to go over opportunities to relate what we're doing in this care of healthy weight, overweight, and obesity in pediatrics with the time that we're in the midst of a pandemic and a lot of needs at work. So we'll relate that together. We're going to talk about doing an environmental scan or a needs assessment, which is a little simpler in order to find out what you particularly need in your community. We have had questions about social determinant of health resources, and we'll swing back to that again today and emphasize again the role of the mental and behavioral health resources in this way of approaching healthy weight. We're fortunate to again have wonderful peers from the FQHC community join us, and then we'll talk about going forward. Next slide. So our community meal today, again, it's been a nice, wonderful group of collaborators along the way. We have Dr. Suanne Connolly, who I think is in New York. She'll let us know if she's not. And her picture should make you just get excited about her presentation. And then you're familiar with me and with Jessica at Denver Health, and Dr. Sonia Fuqua, who's in Mississippi at the primary care facility there, and has been a long friend and colleague in community healthcare, and she'll share insights that they've done on this journey for a number of years now around pediatric healthy weight. Next slide. So let's start just with our meaningful work moment. We've talked about stress and breathing, and we've talked about what we're coming to the table with. Today, we want to, as many people do culturally all over the world, start our meal in gratitude. So think for a minute as you're gathered here and maybe taking time out from a clinic day or a busy day. How has a colleague supported your work? When have you seen that happen? Hopefully it happens on a daily basis, but what comes to mind? All of us get challenged at work in various ways. How has someone supported you when you were in a challenge? So as we think about our families, that we serve and our colleagues that we work alongside, how can we bring that sort of gratitude for our work, for their attempts to rise above a challenge, and how can we come alongside? We know that particularly around overweight and obesity, it's such a long, hard struggle. And so let's think about how we can support our families in that challenge. Next slide. So again, what we're going to really emphasize today is the chronic nature of obesity. So last week, and we talked about the medical part. Early on, we talked about prevention, which is so key. Today, as we're including the community, we're really focusing on when a problem exists. So we're talking about overweight and obesity more today than we're talking about prevention. But we want to include the family, and that's where we're going to look at the whole picture of maybe some are healthy weight, some are struggling with it, and how we can address that in a chronic care model. So there's so many numerous interacting causes. One of their questions they asked was, what is the magic bullet? Sorry, there isn't one. There is evidence-based we'll go over, and there are a number of very important threads that we want to braid together. So next slide. So the evidence base, and you can toggle that, Liz, for community care, which we're going to talk about today, outside of the exam room, not just trying to do motivational interviewing as a clinician and get that 15-minute, even a 45-minute visit in frequently on a special clinic day. That really is insufficient in terms of evidence base. The evidence base says, first of all, we've got to really, really hit prevention hard in infancy and preschool. And then when there is a time to intervene, once we see the weight, the BMI changing more rapidly than we expect for growth, and we're getting into an overweight or possibly, unfortunately, into an obesity situation. That intervention, the evidence base shows, is most successful with 26 or more hours of program contact time, and that's typically in the community. Community health centers are in and of the community, so many of our community health centers do run these programs, but it's not in the exam room. Next slide, or next toggle. Weight loss is not what we focus on. Weight loss is difficult. And so again, we're focusing on chronic care models. When we talk about children, we're particularly not focusing on weight loss. We're focusing on healthy growth, whether that's growing into their weight or whether that's shape shifting a little bit and getting a healthier BMI, but we're not focusing on a weight loss diet. And when we look at standards for evidence base, what standards are out there, we really do want to give you the best of what is known right now on evidence base for this situation. And the evidence is it's a chronic disease, obesity. It's not a focus on weight. It takes time. There's ups and downs. And what we know works includes an emphasis on nutrition, an emphasis on physical activity, tracking and following the data. So follow BMI, we've talked about that. Motivational interviewing, trying to address stigma and bias, and meeting people where they are. And then family involvement. It's not an individual problem. So we know all of that, and we know that that together is the magic bullet. But it isn't clear in the science how any one of those things independently affects a movement towards healthy weight and a recovery from obesity, if you will, other than we know that motivational interviewing, even in short amounts, has a powerful effect. So that is clear, but how all of those others interact and how many of those 26 hours need to focus on nutrition versus physical activity versus education versus family support versus fun, versus meeting social determinants of health, it isn't clear how you divide that up. Next slide. So the time of intervention is only the clearly demarcated and 26 hours plus, but some of the research also shows that when you're talking about behavioral models of intervention, so taking out some of that and really focusing on the behavioral model, it's twice that. So it's 52. So an hour a week is one way to think about that, 2 hours over 6 months. Next slide. So again, we said this in the first module, we'll keep saying it. We all practice a mix of evidence-based and anecdotal care. We know that, but we want to infuse the evidence base here with what you're also seeing in your own communities. And it's not really anecdotal what your cultural care construct needs, but that is also crucially important. Next. So in the beginning of these modules, we showed this very busy algorithm for addressing both healthy weight, overweight, and obesity care. And we had the prevention part in the beginning, and that was just, it looked pretty darn simple, you know, the 4 steps of teaching an infant and child healthy eating, and then the intervention and continued modeling of the 5-2-10, if you will. But now we're really talking about treatment model today. So as we look at these aspects of the treatment model, last week we talked about the one on the far left, the PCP weight follow-up, motivational interviewing, and we touched on tertiary care a little bit last week. This week, we're sort of in the center, and next slide will highlight those 3 circles. So we're really talking about social determinant of health referrals to the community, mental health integration, and what you can do internally around family-supported lifestyle interventions as a community health center. So this is just a mention that the process in all of these programs is to understand where you are inside your health center in this, with this situation of addressing pediatric weight needs, and also where your community is. So in the first module, we talked about looking at your own data. Do you know, if you take out your 0 to 18-year-olds and you break them up into a couple age groups, are you able to give percentages on underweight, healthy weight, overweight, and obese parameters for your children? Can you do that? So that's one of the ways of looking internally as you look at your internal environment. And then what resources do you have for that? Do you have clinicians that have the latest understanding of what to do? Do they have the resources? Do you have the capacity to do something like Dr. Reifenberg talked about last week, or Adrian talked about? And what are your competing priorities at your center that keep you from doing that? So those are all sort of the top of that seesaw up there. And then the other part in the balance that we're really focusing on today is identifying your stakeholders and community partners, and to understand both what is accessible to your families, what is acceptable, not just accessible, and culturally appropriate, and then how can you potentially collaborate? So doing your own environmental scan, there's lots of different ways to do one. Next slide. Is a good starting point with your care teams. Next slide. So you could take this little slide home when you get the copies of the slides and do it with your care team. So you could just look at it as sort of a quality improvement project if you wanted to. What data do we have right now? What data do we want? What are our resources for social determinants of health and community-based organizations? It's interesting, as much as we might do a food security screen, a lot of times that's not linked with an intervention. And I applaud FQHCs because I think we do that better than like private practice. I've asked some private practice pediatricians who do the food security screen, and they aren't necessarily linked to resources, even though they are marking it. What are, particularly for pediatrics, this is a tough one, are mental and behavioral health resources. But remember that maternal stress in particular is directly linked to childhood obesity. So there is a strong connection between stress and obesity. And in COVID times, that's gone up. What do you need for your provider and staff education? Where are you in that? Is there already community interest in this, or is this something you have to drum up? And what do we mean by interest? Is there already community engagement? Is there funding? You know, where are you on that continuum of, yeah, we care about it in the community too, we're committed in the community. And the financial resources, of course, have to be there as well. So that's something everybody can take away from this one is, what can you do in 45 minutes? That's something you can do in 45 minutes, is at least sketch out that. Most people are familiar with the SWOT analysis and strategic planning and those sorts of things. Again, environmental scans is a public health word, and there aren't many of us that actually do one in the strict public health terminology. But we do pieces of it. And so another way of just thinking about this at the micro scanning level is doing your SWOT analysis, both internally and externally, looking at your health center and where you are in this. And then PEST, which I think is a really strange word when you're trying to motivate people, but that's more the 30,000 kind of thing, but I'm just telling you this from the research and when people talk about environmental scans. But we want to be somewhere in between that. So we want to look at the SWOT kind of thing for us at the micro planning, but we also do want to look at the social determinants of health, which is a little bit more at the higher view of things. Next. So how do mental and behavioral health fit in with our pediatric weight management? I'm going to pause and ask you in the chat if you have resources for pediatric mental and behavioral health. And so just put in yes or no. I didn't do an actual poll, but it would be interesting to see. I don't know too many folks who do. Sue Ann does. That's awesome. Wow. Kudos again to FQHCs. Many of you do have at least something for mental and behavioral health for pediatrics. Mine was more, my CHC was more for sort of explosive anger and really very difficult problems. And it wasn't as much for your milder pediatric problems, and we didn't ever use it for obesity care ever. And we also didn't link maternal depression or mental health needs with pediatric weight management. So that is something I've learned just through doing this. Okay, next. So we want to remember that, yes, we are talking about family-centered care. So again, the data on, do you know among your adults with mental health needs, whether there's pediatric overweight and obesity problems in the family next, or vice versa? Either way, are you entering it from either direction? We did talk about stigma and bias. next. And if you missed that, you can go back. There's a module that went into great detail, module 2. And when we integrate our mental and behavioral health, and those words are a little odd, mental and behavioral health, right? We use them sort of interchangeably. They're not really interchangeable. Usually if we're talking about mental health in pediatrics, we're talking about disorders. Behavioral health, we're talking about milder things like family systems and sometimes ADHD and stuff like that. But when we're talking about overweight and obesity, we really are talking about behavioral health more than anything else, and addressing things like bullying, stigma, that sort of thing. Next slide. So motivational interviewing, we talked about that. And motivational interviewing can be taught by your behavioral health folks. A lot of times they are the ones that teach that to staff, but certainly it's something that we can all do, from our nursing folks to our pharmacy folks to our medical clinician folks to our community folks. So I mentioned this in an earlier module, but I thought it was worth repeating on today's, and just so you have the resources for it. The home inventory that was done, and it just showed, again, this is a recent article, 2022, that showed that parental warmth and responsiveness to distress is a family asset that buffers against excess weight. So how are we encouraging in our behavioral health programs, in our community health center programs, in our interactions with families, how are we reinforcing that parental warmth and responsiveness opportunity, and really trying to assess for that. And then it was protective even beyond maternal education and some of the rest. The home inventory, next slide, because we did go over this before. The home inventory, I did list on this module. We didn't have it listed on the other one. It's called the Home Observation for Measurement of the Environment. So you can Google that, and certainly it's a great thing for community health workers to possibly do, for social workers, and again, depending on how your clinic runs, for either your behavioral health folks or your medical clinicians. But again, in the chat, how do you promote family assets and child regulation? Do you have any way of doing that other than the one-on-one clinician to family well-child visit or sick child visit? So put in the chat if any of you do have ways that you promote those family assets and child regulation. Actually, this could be a time, Liz, I'm just springing it on you. If you wanted to do a gallery view and people wanted to jump in, anybody wants to raise their hand or unmute?
Yeah, absolutely. So folks, we should be in gallery view. So feel free, if you'd like, if you're comfortable, turn on your camera. We'd love to see you, but alternatively, just unmute your line and just chime in.
Sue Ann?
Sure, I'd be happy to share with you. I was trying to put it in the chat, but it is a lot to write. We were part of an AAP collaborative on feeding and obesity. And through that collaborative, the AAP has a multitude of resources on responsive feeding and infographics and other information for parents, just a wealth of information. We made some laminated sheets that highlight a lot of that information with links to the websites and some QR codes that the patients can screen to get that information and take it home with them and use it. Also a link to the AAP's healthy weight, or what's it called, the healthy growth, something like that. Look it on my phone. Getting that app to use, which is very nice. A family puts in their resources, puts in their child's information, and then gets lots of resources on, healthy feeding, portion control, responsive feeding, breastfeeding, and from, a wealth of information on different areas that are germane to keeping a child at a healthy weight. So that was one thing that we were a part of that has been very helpful in the resources. I hope that, we've made packets of all that information, tried to give it to all the providers so that they could easily carry it around and have parents look at it and then, kind of take the QR codes and take that information home to use it.
Cool. Thanks for sharing that. Does anybody have anything particularly that they're doing around family wellness and overweight or obesity in terms of your mental and behavioral health staff, or family resilience and warmth and responsiveness? Any of that? All right. So lots of opportunities, right? And again, that's sort of a different way, a newer way of looking at this, is looking at it as a family-centered family approach and something that's multifactorial, and that requires lots of minds and bodies put together to try to address this problem. We'll try to see if there's some good examples out there for you to share. I'm going to go back, Liz, to our regular view. Thanks for playing around with that. So this home inventory, you might want to, again, you might want to Google it and look at it. It's geared towards little people. So again, it's geared in the prevention stage, but it's something that is particularly good for any of you who do home visits. Next slide. So now we have two friends from the community of community health centers who are going to share their stories with us. The first is Dr. Sue-Ann Cole-Connolly, who just shared with us a minute ago. And the second is Dr. Sonia Fuqua from Mississippi. And they're going to each engage with you about how they have used community resources in order to address pediatric healthy weight, overweight, and obesity. So take it away, Sue-Ann.
Thank you so much, Jenny. And I just want to just throw in there that I am very excited, very grateful to be a part of these discussions. Really do appreciate, learning about what you're doing and being a part of it. So thank you.
Thank you. And Sue-Ann, just let Liz know when you want the next slide.
Sure, please go ahead. So I'm going to share with you a program that we developed for our school-based health centers that are all connected to our 5 health centers. All of our school-based health centers are in high schools, and the program is called Shedding Your COVID-19. It's a healthy lifestyle program developed for these kids, particularly whose weight has been particularly impacted by the COVID-19 pandemic, but not at all, exclusive to them. It's a 16-week comprehensive program that focuses on healthy lifestyle changes. Next slide. And the program has 3 major aims. First is to improve healthy weight and decrease obesity-related risk factors in these kids who've been particularly impacted by the pandemic. The second aim is to improve their healthy lifestyle habits, including but not limited to their eating behaviors and their physical activity levels. And thirdly, to improve their mental health and positive attitude. Next slide. The components of this program begins with a physical exam, a pre-physical exam, looking at the children in general, but also specifically addressing obesity-related risk factors and getting appropriate labs. That includes fasting lipid profile, SGOT, SGPT, hemoglobin A1C, and a fasting blood glucose. Then we do some fitness metrics. We get the kids to give us their heart rate pre-program. Of course, all of this is then duplicated post-program. And we get a pre-program blood pressure reading. We then do a robust behavioral health screening. We have the kids fill out a PHQ-9, a GAD-7. They do a self-esteem checklist. They do the EDEQS, which is eating disorder examination, the short form of that. And then the AAP's Healthy Habits questionnaire. We then have structured physical activity coaching that's supervised by the NPs who are, run each health center. They take the kids out 3 days a week for an hour, for an hour. They have sustained activity for about 30 minutes. And these are all on the track, the high school tracks. And they have a syllabus of workouts that they all follow. Then the children are all given strength workouts that they're supposed to accomplish on their own. These can all be accomplished without any equipment. There's video illustration for each of these set of exercises showing them exactly how to do this, and they're supposed to do that twice a week. Then there's nutritional and behavioral health support. Each of these disciplines holds bi-weekly 1-hour group sessions. The focus for the RD staff, our registered dietitians, is on healthy nutritional goals, the emotional components of eating, sustainability of healthy habits, and other connected topics. And for our behavioral health team, our social workers, they focus on how to have a healthy relationship with food, exploring healthy eating behaviors and identifying dysfunctional and disordered eating habits. Also, cultural influences to eating and other connected topics. Next slide, please. So in summary, this program got off the ground basically 16 weeks ago. We just finished our first session of this program, and I can't share the data with you yet. We're still in the process of just getting those last post-test everything together and analyzing it. But just from an anecdotal standpoint, I can share with you that one of the things we found is that attrition is a tough thing. Our patient population, there are many mitigating factors of why they were not always able to engage exactly as they were expected to. Again, the social determinants of health are a really big factor here. We've got kids who may not have, maybe living in a shelter, who may have to hold a job, who may have issues with their school work and needing extra help in school. So there were a lot of reasons that go beyond just, they wanted to play video games as to why they couldn't meet the requirements of this program at every juncture. So we tried to be very forgiving about a lot of that. We also learned that success is not measured just by the scale. There are students, in fact, a few of them who gained weight in the program. But what we learned, and of course the data will tell us more of a story, but what we learned is that although some of these kids gained weight and didn't lose weight, that, was never the only goal here. The goal really is to change your lifestyle, because we all know, those of us who work in this area, we know that, the dieting never works. That's not the way to sustain healthy weight. So that's not the only goal. The goal is to have a better lifestyle, and then everything else follows. So, but we did find is that even when they gained the weight, they improved their behavioral health metrics enormously. A lot of these kids just, went from having a PHQ-9 of, for instance, 15 to a 3. Just things that blew my mind when I just kind of anecdotally took a look at some of the data that we have. And the kids themselves expressed how much they learned about what a healthy lifestyle means. They were just floored by some of the things that we take for granted. And that was very eye-opening for us. We know also that more education has to be forthcoming because, the population has very limited health literacy. And even though I know that intuitively, and I know all of you know that intuitively, When you actually work on a project, it becomes like really front and center what that really means, because, the kids, we realize now that we're going to have to stress to them a lot more about the fact that, if you've just gotten off the couch for the first time in your entire life, that's not a license to eat 3 times the amount of food you were eating before, because a lot of the kids really, this is what they did. And we're sure that's why they gained weight. So we recognize how much we have to reinforce that kind of information. Also, to reinforce, they're so discouraged because they didn't lose weight like in 2 weeks. They were at the program 3 days a week for 2 weeks. Why didn't they lose a lot of weight? And so we have to keep telling them and explaining to them how that works, why that you can't have that immediate gratification. And again, why the goal is not just about the weight per se, it's about the lifestyle. And of course, the weight will follow. And a lot of kids, the degree to which they don't understand what a healthy food is, is kind of off the charts. We also learned that the students really appreciated this coaching. We were flawed, all of us, kind of, in some sense, it is kind of almost, heartbreaking how much the kids appreciated the support they got from the NPs who worked with them and spent this time with them. It was really beyond what we could have ever imagined. Their need for support was really overwhelming at times. And the relationships they formed with the NPs, again, was beautiful and yet sometimes even heartbreaking. The staff really expressed learning more about vulnerable populations and unhealthy weight and lifestyle considerations, things that they could have never anticipated, even though they thought they understood this. And we look very forward to analyzing our data and seeing what that really shows and revising and improving our strategies and trying to move this program forward. So.
Wow. I'm going to pause there for a second before Sonia goes forward and just say, thank you, Sue Ann. And a question. So these students all participated during school hours, or was it after school?
It was basically right after school. The track workouts came just at the end of their day. So they would have to stay an extra hour.
And so did the same group do the 3 times? We have 3 groups.
Mm-hmm. There's 3 groups, one at each health center.
Okay.
Each followed the exact same, program structure.
Okay. And about how many, I know there was attrition, but in the beginning, how many people were allowed to be in each group?
Well, we said that we would take up to 10 because it was our first iteration and we didn't want to be overwhelmed. So we were looking to get 10. We only got 2 at one health center, but we did get 8 at the other 2. And one of them ended up with 6 or so. So, it wasn't.
That's good.
Yeah. And the two turned out to be incredibly dedicated, and that NP worked with them and they really got a lot out of it. And what we ended up doing is choosing ambassadors for next year, kids who are not leaving the school, and they got quite a kick out of that. So we've got a little group that the most dedicated from each school that are going to stay with us and have the title of ambassador, and they're going to help in the future, program iterations with the next, group of students, and they're very excited about it and sharing, and it's really quite remarkable. And one thing I could also tell you is that before I started this program, I had a lot of pushback, even from my NPs and from a lot of staff, teachers in the schools, who reminded us of the stigma that comes with being at an unhealthy weight. And they didn't like the idea of a program for kids who are unhealthy. Isn't that going to stigmatize them? And I said, absolutely not. That is so the wrong way to think about this. We're not stigmatizing anyone. This is something for them. This is a program for them. This is something that is put in place for kids who are usually marginalized, usually are not picked for any team, not wanted for any program, not highlighted for anything, don't get any special attention. This is for them. They will not feel stigmatized. We understand what that means. We understand how to get around that. This is going to be something that they can rejoice in. And that's exactly what happened. And all of my NPs who told me that they even had some fears about that were just amazed at how wonderful it was. In fact, one of the things I allowed the kids to do is they could bring a friend. Now, the friend couldn't be part of the program, but if your friend wants to come and walk on the track, okay, bring your friend. Your friend can join us. And they brought friends, and the friends, you know, because just as I suspected, they were getting all the attention. This was something special. This was something wonderful. The kids loved it. And they really did tell us that this was really their first event where they were the stars, and people would see them out there walking. It's like, oh, what are those guys doing? And
that's so cool.
Yeah, it was
that's exciting. So one other question from the chat is, did insurance reimburse for this? And sort of broadly, how was this financed?
Well, at this point, we basically just did it. I would have to look and even see what the reimbursement was when we did the pre-program physicals to see what we were able to be reimbursed in that regard. And then we actually didn't ask for any. We just did the program. We didn't ask for any funding in any way or bill for any services for any of these workouts. And going forward, you know, that's probably going to be something that we have to think about. How can we possibly bill for the work that we do? Can we bill for the work that we do? Can that, how might that work? So obviously it's easy to do something when you're willing to do it for free, but to keep it sustainable, yes, that is a model that we have to think about.
Yeah, well, it's also a model of strong leadership, I think, and importance that you've got. So we're gonna move on to Sonia, but we'll have more time at the end for a couple questions. And Sue Ann, just thank you so much.
Thank you, Jenny.
Well, hello, everybody. I want to thank Jenny and Jessica for the opportunity to highlight some of the good that's going on in Mississippi. So often we hear about bad numbers in Mississippi, but we want to talk about something good. So I've been asked to talk about community engagement and partnerships as a strategy to implement, weight management programs for our young people. And in keeping with the Come to the Table theme, a community meal accessing non-medical resources, I have a subtitle of Family Dinner. Everyone contributes to the meal. You come for the big family dinner, and there are all the meats and entrees, the sides, desserts, and beverages. Now, gone are the days when Big Mama prepares the entire meal alone. Yes, she may do the heavy lifting. She may do the turkey and the ham, but the family chips in for a successful meal. So you may be the one bringing your favorite dish or the specialty dish that you cook better than anybody else. And if you're like me and prefer not to cook, I may be the one that brings all the nice beverages because we have to drink, right? Next slide, please. So the what, or the meat of the matter, is that our health centers have a goal to impact childhood obesity. So I'm going to call this the what. And our health centers come to the table with a desire to favorably impact clinical outcomes for the community that they serve. But they are not in the community alone. And then, they already have the audience there. They have those who are in need and can be readily identified either by the provider visits, so they can determine if the child is overweight or obese, and there can be an electronic health record query to look at the weight percentiles to find out which children are in need of intervention. In our health centers, frequently there's a champion. It may be a pediatrician, it may not be, it might be the nutritionist in the building, or even a WIC director who deals with children on a daily basis, but they have recognized the need for a program to work with the children who are overweight and obese. Or a program opportunity comes to the health center. You've heard probably in each one of these sessions mention of the MEN program, which is what we're using here in Mississippi. And that's an acronym for Mind, Exercise, Nutrition, Do It. So the program opportunity may come, or the champion at the health center may determine that we need to do something. But, and this is but in all caps, Implementation comes with challenges. And usually these challenges are with resources, whether those resources are human or financial. So what do? We are going to have to take the meat and entrees that are already there and bring along others who will represent the sides, the desserts, and the beverages in order to complete our meal. Now, we're going to talk about organizations and engaging them and partnering with them, but I'm going to really give you an overview because next week, a couple of our health centers are going to talk about their program, and I'm sure they'll mention those as well. So what we have done by way of innovation is with our MEN program this year is to look at those community partnerships. We looked within the community of where we serve, look for people who were like-minded organizations with a willingness to come alongside of us to provide nutrition and exercise training for our families and our kids. One example you see on the screen are the Boys and Girls Club. Okay, that organization serves the same community of the health center with which they are partnering. We have a healthy lifestyle community-based organization that works in the Metro Jackson area, that's Jackson, Mississippi, working with healthy health activity and trying to change people's lifestyle for better health. So we looked at them. And then we are partnering with a local church and utilizing the resources there. So what do they bring to the table? What are the sides, desserts, and beverages that the organizations bring? First of all, they bring space. When you talk about having a program implemented at your health center that involves classes with nutrition training, that involves exercise sessions for the youth, you need space to do that. Does your health center automatically have a space where everybody can sit for a meeting? Do they have a place where children can safely play? So let's not say exercise, but structured play. Well, you partner with an organization that may be able to meet that need. They also bring staffing. I mentioned earlier, you have the champion there, but the champion can't do all the work. And if you know about community health centers, you know that everyone is already wearing multiple hats. So where do you pull from in order to provide the nutrition training, to do the exercises with the children, to engage with them, to make the phone calls, to see that they are brought together? Well, your organizations can assist with that. In terms of engaging with them, take advantage of already established relationships. One of the organizations we are partnering with already have a diabetes prevention program. So some of the parents in that program who already have children who have been identified as overweight and obese, they are already in a program to better their health. So they already have the mindset to do something for their children as well. So take advantage of established relationships. And then just ask. People say, how did you get that group to work with you? Well, we asked. We went and sat with them and talked about the program that we wanted to implement and asked if they were like-minded and wanted to do that. For instance, the Boys and Girls Club. They have the facility, they have a captive audience, and what they are doing is trying to help children be steered in the right direction. The local church has the summer camp. They are meeting with the children all day, Monday through Friday. They have an established curriculum. And when we sat down at the table with them, they actually worked our program into the curriculum. As it relates to staffing, they already have exercise sessions for the children. So that's a part of our program is exercise. So we were able to dovetail with that. So what you do is you meet people where they are. I heard you mention that earlier. And then you take the program to them. So not everybody has to come to the health center, in a small space if you do have the space. And then it's not considered clinical. You know, you're doing something in the community. It's something that's fun. And then it's family oriented, which is what the men program is. We also, like Sue Ann mentioned in her program, we let others get involved. When we were doing our healthy growth checks with our children a couple of weeks ago, the age range is 7 to 13. Well, they had siblings that were 4 and 5 years old. So when we took their weight, their blood pressure, their height, the SIP came right along behind them. We lined them up. We got their weight, their blood pressure, their height. They're not necessarily enrolled in the program, but they will participate as well. So what do you get from this? It's a win-win situation. You are relationship building, establishing good relationships with the organizations in your community. You're also building relationships with your families. And whether you recognize it or not, it puts the community health centers, it kind of elevates your status in the community because they look at you doing things that will help the family. Your participants get improved healthy lifestyle behaviors by way of participating in the nutritional training and the exercise. There is weight loss, though this is not specifically a weight loss program. It may be that because they are changing their behaviors, there's weight loss. There may be maintenance of the weight that they have already have. The children have increased self-esteem. They're learning to feel better about themselves. And then as we look at desserts here, I know they can prevent a delayed chronic disease. So I'm laughing at the picture there, but yeah, this is a part of that meal. We have to have desserts at that table. And then what we look at for promising partnerships, and I talked about the relationships that we had with the partners, but you look at leadership buy-in. So are the organizations that you are working with, is the buy-in coming from the top? Are they okay with your curriculum being blended with what they are already doing? Does it align with their mission or their current work plan? All of the community health centers have a work plan, and they have certain clinical measures they need to meet. They have certain things that they have to do to keep the money coming. So do those alignments with the mission and work plan coincide? Are we all looking to improve quality of care for our children and families? Available funding. We know that there's a little bit of money coming from men. However, but when you are partnering, you are sharing those opportunities. The staff of your other organizations are already doing a lot of the work with the children, engaging the families. So it's not a payout for that. They are buying into the program, so you're not paying them to do the program. They are doing the program with you. And then that minimizes the burden of the staff at the health center. So these partners really come alongside and they allow you to implement the program in a successful manner.
Thank you, Sonia. And we have a few minutes left. Our reminder again that we want to ask ourselves what we can do in 1 minute, 5 minutes, 15 minutes, 26 hours. I mentioned the 45 minutes if you gather with your team and you do a SWOT analysis or something like that. But Sonia, you talked about we're going to have a preview, and that's that next week we will have a number of these health centers presenting on our module on their MEND programs and something called Commit, which is sort of that shaped for an FQHC, all evidence-based and involving mind, exercise, nutrition, and do it, as you said, in collaboration with their primary care clinicians. Are there a specific question for Sonia at this point? I loved how you integrated all of those parts of the meal, and I have to say, hummingbird cake, I make a really good one, and I think that was my mouth is watering.
You have to do it for you all's dessert thing next month.
So also, folks who are listening, we are going to have a dessert module. Stay tuned. By popular request, we're going to add an extra module in July. You'll get notice of it same time. That will focus on the popular questions that people have, and it will be kind of an open forum for you all to ask some of our speakers more detailed questions like metabolic screening and partnering with the community and addressing bias and stigma and that sort of thing. So that is coming up. Any questions? So Anne, did you have a name for your program that went with the not having bias and stigma, or you just invited them?
It's called Shedding Your COVID-19.
Oh, perfect. Okay. I didn't realize that was the name of it. That's great.
Right. It's like a play on,
Yeah.
the freshman 15.
Yeah. That's fun. Okay.
And it takes the edge off. It kind of, even though
Playful.
it's playful, and it's not really just for kids who've been particularly affected by the pandemic, but it sort of gives them a crutch, like,
Yeah.
Yeah.
And it's not shedding weight, like you said, necessarily. It's shedding
Right.
the stress too.
Right.
What's on the next slide? In case I am messing up here. Yeah. So next week is a feast of innovations. So we'll have all sorts. It won't be me talking. Jessica is running that one, and it will be drawing from the groups that have received funding through NAC and the CDC to have these healthy weight initiatives. There's some resources for you: Smart Moves for Kids, the Bright Bodies, an environmental scan, and that home inventory. So thank you all, and particular thanks to Sonia and Sue Ann, who just quite willingly and kindly jumped in and shared with us their beautiful work that they're doing.